I think it's just 8 o'clock, so 2-3 minutes we can wait. At KGP also, sir, 8:30 we say, but we usually 5-7 minutes extra.
We wait for 5 minutes more.
Yeah.
8:35, and then we start.
Yeah.
Otherwise, consultants, those who have come, they get late.
Correct. Yeah. I can't hear you.
Satish, you are muted.
You're not audible.
Okay.
Yeah.
Thank you.
I can't hear you.
So, good morning and welcome back to Saturday Club of Baroda meeting after a gap of 7 weeks. And we have with us Dr. Meeta Saxena, who had very gracefully agreed to give this talk because the earlier speaker had some reasons, personal reasons, so he couldn't make it. So thank you, Meeta Ben, for agreeing at a very, very short notice. Actually, Meeta Ben is not new to Saturday Club of Baroda. When it was being held offline also, I have heard her several times. And here in the online meetings also, we had her about 3 years back in July 22.
Okay.
Now today she will be talking about neonatal brachial plexus injuries and sequelae. To briefly introduce her, she is a very senior consultant physiotherapist in Vadodara. She has her PhD in her subject. Currently, she is the head of the department at KGP Children Hospital, Vadodara.
Just consultant.
87 and consultant.
Just
she has experience of more than 3 decades and has delivered several orations and talks and won several awards also for presentation. She is a teacher and trainer at national and international level. She has to her credit several publications and prize-winning presentations too. And she has conducted several workshops on training and counseling about ergonomic workspaces and general fitness in several industries and institutes also. And her current area of research is fitness for children and adolescents. With this brief introduction, I request Dr. Meeta Saxena to go ahead with her talk. Meeta, when you have about 40 minutes to talk, and we'll keep some 10-15 minutes for discussion. So over to you. Thank you.
Yeah, thank you so much, Satish bhai. So just before I start, I wanted to say when you said offline, the first time I presented in Saturday Club was when Dr. Satish and Dr. Daksha Shah's clinic, they used to give that for the mornings for Saturday Club.
Yes.
So I remember I've spoken over there on fitness and a couple of other topics over there.
Yes.
So
Yes.
it's a long association. Yeah. So I think I'll just start now, sir.
Yes,
Okay.
please.
So as you know that, of course, you can call it neonatal brachial plexus injuries or brachial plexus injuries at birth. And I'm also going to focus a little bit on the sequelae, because as we have been seeing these children, we have realized that how they grow and what is the quality of their life has become very important for us now. So 1 minute, I need to, okay. I need to actually lower the.
We are able to see your slide, Meeta Ben.
Yeah, but my end is getting cut off. Anyway, okay. So I'm trying to see if I can shift it slightly left.
Yeah, with your touch screen, no, you can shift it to the upper panel. But this is inevitable. This this little obstruction is always there.
I know. Okay. Anyway, so so usually these injuries occur perinatally as a consequence of birth trauma or during childbirth. And normally now we have found that you need a team of specialists to deal with these children as they go on throughout their lives. And how it's going to be classified, I'll just come to that. So I looked up a lot of systematic reviews again after speaking with Jagdish Bhai 2 days back when I decided to do this, because he said that with the increase of cesarean section births now, this should be less. But this in 2023, this publication is a huge systematic review of brachial plexus injuries after cesarean section births. And they have covered all of these databases, and they found that in spite of the increase of cesarean section, the incidence of brachial plexus injuries for vertex deliveries has gone up from 2 to 2.5 to 3 in 1,000 live births. And the cesarean section mode has gone up to 1 to 1.5 in 1,000 live births. So it's definitely not going down for sure from what we were seeing 10 years back. And in fact, there seems to be a slight increase. Of course, the study also says this was done in UK, but they are saying that there is also a regional bias. So there will be some countries where the incidence will be much higher than 3 also, and there'll be some where it may be lower. So just to show you the, I just thought I'll start with a video. This child came to me about, now this baby is 2 months old. So they came to me at 16 days. And as you can see that the baby is completely flail at 16 days. Because of this, the child is also turning to one side. The neck is being kept only on the good side, which the child uses. So we are not only looking at the hand or the arm, but we also need to look at the posture of the body, because all the neonatal reflexes are integrating at this point. So for us, it's very important to look at that as well. So this was a child baby with a severe dystocia and completely zero movement in the right side at 16 days. And unfortunately, we have this baby is now 2 months old and is still not doing well. So we'll come to that. So when you look at the brachial plexus, you can see that the brachial plexus comprises of nerve roots from C5 to T1, and they go over the clavicle. They go under the under the clavicle and over the humerus, the shoulder joint, and therefore all these are the areas where you can actually get the trauma over here. So as you know, it's a complicated structure of the peripheral nervous system. And you can have either traction injuries, where during delivery there's an abnormal stretch on the surrounding structures. It can be behind the head, around the shoulder. It can be worsened by a cord around the neck or breech positions. Or you can have pressure injuries, direct trauma or pressure on the nerve roots. And this is something that also happens during cesarean section. If there is an emergency cesarean section and the baby is already stuck, then pressure injuries are very common at that time. So probable causes can be large babies, breech or pelvic births, gestational diabetes in the mother, shoulder dystocias, the mother being small and the baby being quite large, so more than 3.2 kg, and a prolonged expulsion phase. As you can see in this diagram, the shoulder gets stuck just behind the pubic symphysis over there, as you can see over here. And that when the baby is being extricated, that is when you can see on the right side, the whole plexus gets affected. You can see on the other screen. So the damage over there happens because when the baby is being extracted over here. This will cause more of a traction injury, and this is more of a compression injury, because when they are pulling the head out and towards the shoulder stretch gives a pressure on the baby's through the head on the baby's raised arms. And especially this is more, compression injuries are more common in breech presentations also. So this is how the injury occurs and what the repair happens. So you can, the top one is the normal nerve. Then you have an avulsion injury. That means there's a full cut in the root. Or you can have a rupture, which is little bit away from the root. You can have neuromas, which can usually resolve spontaneously, and you can have neurapraxia, which is just a pressure. So usually avulsion injuries and ruptures, you need to have surgical interventions. I'm not going to speak on any surgical thing because it's a whole topic by itself. And when you have neuromas which are resolving and neurapraxias, that will be the mainstay of the therapy, will be physical therapy. So this is how the nerve roots, C5, C6 branches, which will supply the musculocutaneous. The C8, T1 is radial nerve and ulnar nerve, and the C7 goes into the median. So Erb's palsy is when the upper trunk originating from C5, C6 nerve roots is affected. And usually the causes will be indirect injuries, vacuum or pressure. And what you will find, what are the signs that you will see in the baby? There will be a inconsistent or an asymmetrical mororeflex. There will be a lack of arm movement, diminished sensation for the baby, partial or total arm paralysis, and a weakness and poor grips in the arm and poor grip strength. For Klumpke's, it is the C8 T1 route, usually happens in a breech delivery, and traction and fall in the abducted arm usually cause a lower root involvement. There is loss of sensation, paralysis, lack of movement, stiff joints, pain, and claw hand. Here you can see I've compared a baby's position of the arm. So the right side is the Erb's palsy, which is the upper nerve roots, where you can see the arm is more pronated and with a wrist drop. Whereas in the Klumpke's, you can see that the arm is not much pronated. It's in neutral position, but there's a clawing in the fingers. So this is how you can differentiate on presentation. This was a baby who came to us, and you can see the fracture of the humerus, which is on the left side, actually. So the baby was plastered over there. But to our surprise, we found that so not only was there a fracture created in the shaft humerus on the left side, but this child also had a right-sided Erb's palsy. So after 3 weeks of plaster and everything, the right side, actually, the plastered side was doing pretty well, but the Erb's side, you can see the movement. So bilateral hand movements and all of those are affected, and the child doesn't have much midline movements and all that. Whereas the left arm slowly in 3-4 weeks recovered and was giving good movements over there. So this was a child with complete like involvement over there, over here, as you can see this baby. This is a child who had complete brachial plexus injury with Horner's syndrome. So as you can see on the left side, the arm is just lying limply. Is it not playing? Yeah. As you can see, the arm is just lying limply. This is again a small infant. And the child is turning, looking, but this child had a Horner's syndrome, so which is ptosis, an eye drop, eyelid drop, meiosis, and there was a rash, and also little. They have the symptom of sweating, sweating and rash. So this child, there you can see in sideline also there is no anti-gravity movement. The wrist is dropping, and the child is not able to pull the arm forward, as you can see here. So again, these are the symptoms of Horner's syndrome. So sorry. So this is a child who had, as I said, full Erb's palsy with Horner's syndrome. So that means the sympathetic nervous system in this baby also got affected. So the sympathetic supply also had a problem along with the peripheral nerve roots. And that is why they had Erb's palsy with Horner's syndrome. So then radial nerve injuries are usually quite uncommon in neonates unless there's a direct fracture of the humerus, which is affecting the nerve, peripheral nerve in the radial groove. But in adults, it's very common to have this. So the fractures in newborns, unless you have created a fracture, other than that, it's not that common to see those. We had a child with radial nerve palsy, a newborn baby, and the signs are usually the children have a lot of pain. There is a wrist drop, lack of movement, weakness of the hand. So the wrist drop is something that is very easily seen in radial nerve palsies like this. Median nerve palsies, I have not seen an exclusive median nerve palsy. It can be associated in a complete brachial plexus involvement. So it's more in slightly older children or in adults. Again, the cause is traction injuries or a penetrating injuries or supracondylar fractures. And you will have a claw hand of the first and second fingers. Unlike radial nerve palsy, where you will have loss of sensation, I mean, you will have a claw hand in the last two fingers. Again, for children, it is only if there is a fracture around that area. Otherwise, shoulder dystocias will not cause a exclusive ulnar nerve palsy. That will be more the complete Erb's or the Klumpke's. Those are more common over there, as you can see. So when I did a lot of literature review to support the treatments or therapies that we are carrying out, and systematic reviews in 23, 19, journal studies in 20 in the Journal of Hand Surgery. Then in 2023, there was a iPluto task force where there was a worldwide consensus of outcome measures based on your brachial plexus injuries. So they have said that not only will you look at supportive treatment in the early years of DRICE, but you will also look at functional uses of the hand, the pediatric quality of life scales, and a pain inventory as the child grows in age. So the consensus is that now you don't just treat the child in the first 6 months or 1 year or whatever. You have to keep monitoring these children as they grow. This is how we do our first assessment. I've just put the template. It's not very clear, but mainly we do assessments at 1 month, 3 months, 9 months, and 6 months and 9 months. And after that, once every year. Every year or once every 2 years, we call the person back to see how they are doing in their functional activities. So we do active range of motion, passive range of motion. So this is a template, standardized template, which is given to assess. So coming to management, we do conservative management will consist of immobilization, maybe with splints. There may be, we usually like to give a little bit of electrical stimulation as a support. There's sometimes constraint in induced movements as the child grows, but not in the early stages. And later on, you might want to, if the child has developed a tightness of a certain group, or it's a neglected child who has come much later seeking therapy at 1 year or something, you might need to look at botulinum toxin at that time. Then, of course, you have your surgical management. So if there is no spontaneous recovery in the first 3 months of life, then the surgeon within the first 6 to 9 months will go in for a primary nerve reconstruction and a repair. So that is when, so at 3 months, if the child comes to me very early and I have seen how they are doing, we will decide the treatment protocol over there. So that first baby that I showed you, who has a complete involvement of the brachial plexus, at 2 months right now, I'm not getting much movement. So in another 3 weeks or so, I will probably have to refer that child to a surgeon. And then they will decide whether they want to do a reconstruction or wait. And of course, the older children, once they are 2.5 or 3 years and they can be functionally trained, only then they go for secondary reconstructive surgery, which could be a tendon transfer or a reconstruction of a certain muscle group to get some kind of function into that hand. So the focus of rehabilitation is, as I said, has to extend through the life span and not just improving. You know, what happens with us is, okay, now he's got some power and all away gare karya karjo. So we don't do that. Actually, we want that, is this child able to use both hands? Can they participate in school activities? Can this child go into sports and so on and so forth? And so long term, the team works to give comprehensive support for not just physical, but also emotional, social, and life role concerns. This is a 2023 very nice paper, which said that we are not looking at our children enough as they grow. So how is the template? What do we do? When the child comes in, the first thing is to make a diagnosis and how much is the damage to the upper limb, which kind of brachial plexus injury are we dealing with? Do you suspect a fracture or some diaphragmatic movement is also affected? So you may need to go for radiological assessments. Do you want to do a neurological assessment, including a nerve conduction study? All of these at 1 month. And then before 1 month, we do our physiotherapy assessment. And then, of course, repeat it every month. And we start supportive physiotherapy right then. So if there is no significant improvement, then by 3rd or 4th month, you will need to refer the child to the relevant surgeon. And they might do a CT myelogram, and between the 3rd and 9th month, there is a reconstructive a repair surgery for the nerve root itself. And then we continue with post-operative physiotherapy. However, on physio, if there's a significant improvement and then the improvement is continuing, then we do not go for surgical interventions. We just continue with supportive care over there. So what are the goals of physiotherapy management? We prevent deformities. Now, this is something very important and we miss out on, because when you start getting flicker contractions and all, you say, okay, now the arm is recovering well, do that. But it is the tightness of certain groups which gives up, eventually it gives you a postural asymmetry. And then that child later on, you don't realize that because of the dysfunction of the hand, the child has developed overall, the posture is affected, the breathing is affected, midline functions are affected. So, of course, so prevention of deformities, including tightness of the pectoral muscles, the scapular muscles, is something that we look at completely. Then recovery of the movement and muscle strength. We want to reduce the stiffness and the pain for the child, and of course, prevent secondary complications. So usually what do we do? Proper positioning. We teach first days of life. We teach the mother what to do, perform basic research over there. And then passive exercises according to the instruction. If the child is admitted, we start there. As they go home, we give homebound. And then we call them, depending on how often they can come and where do they stay, we call them in for outpatient care. By the 5th week, intensive physiotherapy, we give a lot of kinesiotherapy, which is giving a lot of tactile and proprioceptive inputs to this child's hand, to the different groups of muscles within that hand. So that we do ourselves. And if the mother is good enough or the parents are good enough, then we can teach them to continue it also. 3 to 4 months, again, as I said, if there is some neurosurgical intervention required, then that will be done around 4 months to 6 months. In the first year of life, you may or may not do a neurosurgical operation depending on the doctor's choice, surgeon's choice. But after 2 years, in case there is a low functionality of the hand, then a transplantation of the tendon or a group of muscles can be done. So this is how we go about the child over there. So positional therapy, I have got a couple of videos which I'm going to show you. We place the child. Okay, now there was one very good paper about 4-5 years back, which I attended in a conference. Earlier, what used to happen was that the arm used to be placed in this kind of an aeroplane position, you know, like an aeroplane wing. But what they say now is that for the first 3 to 4 weeks, do not give any further stretch on the brachial plexus. So that means you keep the shoulder at the level of 90 degrees or below, and let the child's hand rest in a good comfortable position in the midline across the body with slight flexion, so that you're allowing the brachial plexus to heal, which has had a traction injury anyway. So that is what is the change over the last 4-5 years, because in the earlier days, we used to, even the orthopedic surgeons used to advise that, and we also used to give that movement. But we don't do it in the first 1 month of life anymore. Then we give a lot of tactile stimulation, gentle passive active exercises. You have to teach the mother how to support the shoulder and the shoulder blade during feeding, bathing. And I have to advise so many that when because in our country, we have a lot of, people coming, the guys coming in for the malish. So we have to teach them how to hold that shoulder in position. And I usually advise the mothers to do the oil massage and all by themselves, but they don't want to do that. They want that maid to come and do it, the ladies. So then we have to counsel them accordingly. And then we give a little electrical stimulation to maintain the tone of the affected neural pathways. So here you can see for that same baby. See, I'm teaching the mother how to give the movement, where to hold, gentle joint compressions I'm giving to the baby. And I've used a ball. So the ball gives a proprioceptive feedback. Now see, when the child is turning, I've told the mother, do not allow that. Let the baby stay a little more towards this, because then there will be a traction again on the shoulder over there. So position of the rest of the body is also very, very important, as you can see over here. So then we are giving tactile stimulation, we are giving, and I'm constantly teaching the mother also over there. And we give stroking. We use different textures like soft cloth or a slightly roughish cloth. And we are using that. So I've brought to show her that you can use a cloth. And I've counseled her not to take the hand above the shoulder and just gentle tactile stimulation to start giving proprioceptive and tactile feedback to the child, which is very, very important, both in supination and in pronation. This is because the baby is only 16 days old. That's why. So as they grow, we will increase our exercises. So now gentle joint compression over there. So I'm counseling her that be careful, otherwise she will develop a positional torticollis in the neck because of keeping the head turned only on one side. So that is also important. And then we always start giving the baby midline stimuli, as you can see. So I'm holding the other hand and taking it towards the mouth. So we give a lot of positional therapy like this. Coming to this was one baby, left Erb's palsy. This child did very well. He had an Erb's palsy, but within 2 months, there was very good recovery for this baby. This is at about 2 months. And see, he's even able to, in 2 months, there was good recovery on spontaneous recovery as well as on physiotherapy. And the child is trying little bit, still little difficult to extricate the affected hand in position. But the child is trying, and we are helping them because the prone positions are very important for us to give to the baby because it helps the spinal muscle, it helps the neck movements to start coming and all of that. So this is a baby who did really well. Okay, now we have the same child. So we are giving a lot of neck movements on the same side. We are giving hand movements. Now, because the child is more than 2 months old, we are giving overhead activities also. But we did not do that in the first 3-4 weeks. So as you can see, over here, yeah. This is, again, you can see how the child is extricating, how he is taking the hand out in prone. See, he is able to take out, but he's not able to take good weight at 2 months. But by 6 months, this baby was pretty good and he did very, very well. This child is now about a year old. Between 15, 16 days and 19, 20 years of age, I have right now monitoring at least 10 brachial plexus injuries currently. That is the amount of cases that we are seeing over here. Again, you can see over here, the baby is able to take the hand up quite well. There is midline function now. And by 6 months, he was doing pretty well. He's starting to roll and all of that. So we look at all the developmental issues as well over here. This is a baby who came to me very late. So she came to me only when she was about 15 months old. I'm sorry, I think the video has turned. I tried to put a blanket, to blank the face out, but I wasn't able to do that. Okay. So this is a child, and then so she had some residual deficit in her pronators and in the biceps. So at 2.5 years, she was operated in Ahmedabad. I think Dr. Molincha was doing it. And then he sent her back. So at this point, the electrical stimulation is not a supportive thing to maintain the pathway. This is now being used. It's a different current now, and we are using it for re-education. So we are giving the electrical stimulation to re-educate the movement. So as the current goes through, we ask, it is something like a biofeedback using an electrical current for a small child. So we usually like to give the babies in the mother's lap so that they are comfortable, because that current is going through, they can feel that. And then as the surge comes, we give the appropriate or desired movement along with that. This is a child who again has done the proximal muscle groups did very well. And the strength has come. See, she can lift this huge thing over here. She is now around 2, she's 2+. But you can see the pronation on that hand. As she lifts the hand still remains in pronation. So this child may require a little bit of a tendon transfer after another 6 months or so. The mother is very happy because functionally the child is able to do almost everything. And the same thing over here on the right side, as you can see, there's an asymmetry in the left hand compared to the right hand. And usually in Erb's palsies who do well, fairly recovering well, the supinator and the biceps come last. And these are the functions that we work on as much as possible. That is how we do that. So these flexion synergies remain. So we have to teach the child how to do extension, how to supinate for a lot of the time. And especially if they are right-handed, then, and if the brain is not there, we have to teach them to start writing with the left hand and all of that, unless they can hold a grip. This is another child, Shivain. He's doing pretty well. At 6 months, you can see Shivain is able to take the hands out. So at 6 months, he's got enough function, but you can see the hand remains in flexion, and the hand, see, you can see the hand remains in flexion, and he's not able to extend the hand breadth. And this is where I'm giving therapy to the child. Sorry. This is where I'm giving, now the child is big enough at 6-7 months, and in a play way, we are giving there's a thera tube that he's holding in his hand, and we are giving him resistance for extension, because that is the movement that now needs to be built up. So there are ways even in these small infants to give, using a lot of play and a lot of counseling and using the help of the parents and the grandparents, we try and give resistance using these therabands also, as you can see. And then the same child is now 15 months. That was at 6 months. Now this baby is 15 months old. You can see he's using both the hands, as you can see, but there is still a little bit of as you can see on the left hand, see, the left hand doesn't go completely into overhead position. So we are working with that. And this is the splint that you can see that we have given the child. So now the child, when he's alert and awake, we leave the hand loose. But when the child is sleeping, then, then we, this is, I think, then we give a splint so that the hand is held in extension and supination. So it's a splint when we give, usually we advise for 3-4 hours during the night and during the nap times. That is when we are holding the hand, so that we are breaking that flexion and pronation synergy for the child. And this is a big child. He is he is doing 2nd year of engineering now. This child came to us initially when he was a newborn for surgery. You can see he's trying to lift. See, this is the movement that he has in the affected hand. And he did not want his body and everything. He's very conscious. So he did not want to be seen. So I said, okay, we'll just take your hand. See, he can use the remote. He can use the phone. He's 19 or 20 years old now, getting on for 20. And he's in 2nd year engineering. He's able to ride a 2-wheeler and everything. But you can see he is so conscious of that little bit of residual deficit that has come, that he does not want to be photographed or put anywhere. So he said that, ma'am, I will only give you this much of a video where you can see that how I'm holding the thing. So he went in for a surgery at 3 years where a tendon transfer was done. And after the tendon transfer, he recovered a little better function. So as I said, he can drive. He's going to college, he's doing engineering, but he's still very, very conscious about his appearance and his look. So to conclude, especially in girls, now the other 2 children, the girls whom I showed you where we were giving the re-education, she also, her mother is very worried because she said, "Amai to chokri che, અમારું હાથ આવું રહી જશે બેન તો શું થશે. This is the concern of mothers and parents and grandparents, especially more in girls as compared to boys. But it's not that boys are not there. Vivek, as you saw, that last big child, 19-year-old, is still very, very conscious of his appearance. Then we have to look at function, not just ki haath uthe che ke nahi, but we have to look at their activities of daily living, sports. I had one child who's now about 12. Her mother said, I want my daughter to play tennis. I tried to tell her, can we choose some other sport or something like that? But she said no. So I said, okay, do one thing. Let her use the other hand. Let her start playing tennis since you are so into it. So then she came back at 12 and she said that obviously she's not be able to play tennis. And they were like from a very wealthy family going to Navrachna school. So they were so conscious of the child's appearance and there was a very minimal deficit. But even that can affect the quality of the life. So then a lot of the time I had one child who's now about 6 years old, where they did not know, the child didn't know that there's something wrong with the hand, because they recovered fairly well and the child was using the hand. So there were fine motor deficits which we could pick up in the function, but the child didn't know, because the parents said, we have never told the child that you have something wrong with your hand, otherwise it will affect her psychologically. So this is also an aspect that we to look at, whether the parents or the family wants to tell the child or does not. And especially we have to look into, they feel very conscious when they are in, because children will tease you and ano to haath nathi chaltu, and jo how the hand is functioning, especially when they are entering adolescence. So these are all a lot of issues. So brachial plexus injuries can affect quality of life. More females than males in India. Families are affected. I don't know about the other ones, but I read a couple of studies here where they said that going into adulthood, they are very worried. And we have actually seen that these people are very concerned about the cosmetic appearance a lot and more than function. So I think that's how it is. And yes, I can take any questions. We have Jagdish Bhai and Dr. I.C. Patel. So.
Yeah. So Mitaben, can you please stop the screen sharing so we can have some discussion?
Sure.
So on the screen above, you will find a stop screen tab.
Yeah. Slideshow animation.
We are still seeing your screen actually.
Okay, 1 second. Stop share. Can you stop the share?
Yes. Use that.
Okay.
And
You can. No, I am not.
No, I can't do
1
that.
second. Let me open like this. Okay, here.
Okay, I'm doing it. I'm stopping.
Okay, you can.
Yeah, I've done it.
Thank you so much. Okay, now I'm getting the whole thing. Yeah.
So big thank you to you, Mitaben, that at a very short notice.
Yeah.
Mitaben was so sincere about not having any technical glitch. We had a dry run yesterday evening. For 20 minutes.
Because lately, sir, we have been using a lot of Google Meet.
Yes.
But I have not used Zoom for quite some time.
Yes,
so I was a bit worried whether
it only reflected your sincerity about whatever.
Thank you so
much.
much.
I've seen this in your patients also.
Yeah.
It was wonderful to know about psychological aspects also. As pediatrician, probably we forget after referring the patient to an orthopedic surgeon or a physiotherapist.
No, even therapists do that, sir. We also used to, not bother much ki chalo hand function aa gaya. Okay, you're done now, continue at home. But we never monitored. Now I work a lot more on monitoring these children as they are growing.
Right. So follow-up is very important. We have Dr. Sridhar Joshi, who's a neuropediatrician. Sridhar, do you have any comments? Then we can take up some questions.
Correct.
Yeah, it was a very wonderful talk. I've been hearing ma'am since long time. It's a very beautiful talk, and the main aspect of the function, and that's what madam emphasized, that when to refer for surgeries were also important. We see a lot of neonatal brachial plexus injuries. They do get referred to us in the neonatal period, and we do start early intervention. But at 3 months of age, if biceps function has not yet come, then it's time we do tell them that do go to a hand surgeon or orthopedic surgeon and go for operative intervention. That is important. Otherwise, if they don't go, they should continue therapy. The only thing is contractures set in. If the contractures set in, then it is very difficult cosmetically as well as functionally to get a
Correct.
good hand function. So the role of any pediatrician or neurophysician is to early diagnose the etiology and then give early physiotherapy, hand functioning, and prevent contractures. That is the main thing,
Right.
so that we can work on them further. Do a staged procedures. It would not be a one-time surgery. It would be a staged procedure sometimes.
Correct.
Mm.
Correct.
And to differentiate between herbs and a clumkey. So usually it is herbs, but sometimes it could be
There is
clumkeys.
clumkeys.
And in herbs, we have to differentiate whether it's preganglionic or not. So whether there is associated Horner syndrome or not. Because
Yeah.
if there is associated Horner syndrome, then the outcome would be a poor outcome as compared to a postganglionic brachial plexus Erb's palsy.
Correct.
So that is what we see as when we go to consult, whether it's preganglionic or postganglionic injury.
Yes. I think you joined in a little late, Sridhar bhai. I showed the template
Yes,
over
sir.
there.
Yes.
I showed
Yeah,
the
I know, ma'am.
comparison also, and I also said that immediately if there is a break then we have to immediately refer. And
No, I just
neuromas
said,
also
yeah.
need to be looked into whether they're resolving or not.
Yes, sure, ma'am.
Absolutely, you're right. And my baby, as I said, that latest baby who's now about getting on for 2.5 months, I'll be referring them in the next 2 weeks for assessment to the surgeon, because that baby is so poor. So you are right, absolutely right. We don't just continue mindlessly, that chalu rakho ye wo. We have to keep on reviewing, and absolutely correct. Yeah.
Have there been any comments from you? Or any questions from any other participant? So if there are no questions, I think we can end the session here. Thank you once again, Dr. Meetaben and the participants.
Thank you.
Forward to your, the other topic that we were
Yes.
discussing before meeting.
Correct. We'll do that
Months
later.
also.
Yeah, sure.
Thank you so much.
Thank you so much, Satish bhai.
Thank you.
Okay, and thank you to the Saturday Club.
Thanks.
Okay, bye-bye.